anchorage. You will study in the next semester about appliances. Some of these appliances we use for anchorage. In the next semester, you don't have lectures. That's why all the information from first and second semester are on the from 4th and the 5th year are presented during our lectures at the 4th year. So what is this anchorage? Anchorage is resistant to unwanted tooth movement. When we are applying the orthodontic treatment, we have to remember that for every action there is an equal and opposite reaction. It is called third Newton's principle of dynamics. Anchorage is resistant to unwanted tooth movement. Depending on how far the anchorage unit can move, it can be described as minimum or moderate or maximum. Maximum anchorage, in fact, this kind of anchorage we can achieve if we use some kind of pads, temporary anchorage devices like micro screw, mini screw, or some kinds of dental implants. Here you can see different kinds of anchorage, and here we have situation after extraction of first permanent premolars. This situation we have when we are planning orthodontic treatment with fixed appliances, and we have patients, for example, with a huge protrusion of upper incisors, huge overjet. In this situation, we can plan this kind of extraction. And now, we could have minimal anchorage. What is minimal anchorage? A situation when this space here is closed also by this teeth, but usually the mesialization of buccal teeth is bigger than distalization of anterior teeth. Here, moderate anchorage is this situation when we close this space by distalization of anterior and mesialization of posterior teeth. And maximum anchorage is situation when we don't want to change the position of this teeth. We want to close all the space with distal movement of anterior teeth. It's only possible when we use micro screws or some kinds of screws which are placed into the bone. Optimum forces for orthodontic tooth movement. So when we are planning some kinds of movement of tooth or teeth, we should to use the force. The force is usually we estimate it in grams. And here you can see the value for one-rooted teeth, and here for multi-rooted teeth. And the simplest kind of tooth movement is tipping. What does mean tipping? So when I push a crown, like here, when I push this crown, the crown goes backward, but the root go forward. So here will be the center of rotation, backward, and root goes forward. So this kind of movement we can achieve with fixed appliances, with braces, but also with removable appliances. So if we use upper plate and we activate this labial arch, we achieve tipping. As you see, we don't need a huge of force to achieve this kind of movement. bodily movement. What does mean bodily movement? This is translation. So when we add the force, which change the position of all parts of the tooth. So crown and the root go in one direction. Is this kind of movement you can see here. So force is here, but all tooth, root, and the crown go backward. You see in the red line, we see the distalization of this incisor. In this situation, we need more force, and this kind of movement we can achieve only when we use fixed appliance with braces. Root uprighting. It's also a kind of movement. We don't talk about this a lot of, but now we have rotation, extrusion, intrusion. A few days ago, somebody during the labs asked me what it means, extrusion and intrusion. Extrusion is situation when we pull the tooth or teeth from the bone outside. Intrusion when we push it into the bone. So look at the forces. Extrusion, we need in this situation more force, bigger force than in intrusion. Why? We should to be very, very careful if we're planning intrusion, because if we use too much force, we can expect resorption of the apical part of the roots. So we should be very gentle during treatment with this kind of method. Rotation and extrusion and tipping. You see that we use the same forces. Rotation, it's not very easy movement, because to achieve rotation, we should to add the force from both sides to derotate the tooth. So we should to have two places when we attached to the tooth to achieve correction. So sometimes we don't use only braces, but we can add, for example, additional button on this tooth to make this rotation possible, make it faster. It's much more easier achieve rotation of the anterior teeth, like incisor, because we can derotate incisor even if we use removable appliance, because we can add in upper plate, for example, when we have rotation of the central incisors, we can add the force from on one side, from the labial arch, and from palatal side, we can add the force from the springs, and we derotate this tooth easy. Of course, if patient cooperate and wear appliance. And different situation is with multi-rooted tooth, with premolars, molars. In this situation, it is rather difficult to achieve the rotation with removable appliance. Also, canine are one-rooted teeth, but you know that the root of this tooth is very long, and rather the movement, especially rotation of this tooth, is sometimes it's difficult to achieve rotation of this tooth even during treatment with fixed appliance, especially if we have rotated canine in lower arch and we have man who is after 30 years old. In this situation, this kind of movement could be very, very difficult. What anchorage do we use in orthodontic treatment? So reciprocal, you can see it here. This is a situation when we want to close diastema. Everyone want to know what is a diastema. Diastema is a space between central incisor. So we can use elastic chain, as you see here, connect both braces, and the movement of both teeth, it's the same. So it's the same force. The same force is we add to these braces, and we expect that each one tooth close this space with the same achieve the same mesialization to close this space. A reinforced anchorage. So here is the situation. This kind of anchorage still we use, but nowadays we have micro screws. That's why we use it much more often. But you should know that this method was also used in the past. So as you see here, we can connect distal teeth together, and in fact, this all the tip on right side and the left side in the maxilla has the biggest surface of the root, so probably they will give more resistance for the unwanted anterior tooth movement of this tooth. So we expect only that this one goes backward. In fact, in this kind of anchorage, we can expect, unfortunately, movement of the buccal tip. So it's not a very good kind of anchorage. In fact, it's not maximum anchorage as you see here, but it's a moderate anchorage. Next, stationary anchorage, also used in the past more often, but still we can observe this kind of anchorage in lower arch. So as you see, what's happened here? It's much more easier to achieve distal inclination of the crown than bodily movement of all the teeth backward. Here we need only 35 grams. If we want to achieve bodily movement, we need 70 grams, so 2 times more. That's why if we don't want to achieve big movement of buccal tip, first we are making only we achieve only distal inclination of the anterior tip, and then we make correction of the root. So we need less force during this treatment. Less force means less possibility of resorption of the tooth. Okay. Anchorage cortical. This kind of anchorage we can expect if we torque the roots of posterior teeth outwards against the cortical plate. The same kinds of anchorage will be present if the patient lost very early tooth or teeth. What we see. Look what's happened with alveolar bone. The cortical bone is here, and between them, the bone which fill this space is resorbed. So it's very difficult to bring this tooth through this very, very narrow cortical bone. So it will be kind of anchorage, but sometimes it's for us good situation if we have this kind of anchorage. And in this situation, in our arch, it could be difficult to close this kind of space, because what we observe usually, if we have this kind of situation, this tooth we don't observe bodily movement, translation, but peeping. So we observe that crown goes forward and close the space, but root goes in opposite direction. So it's not bodily movement. So we don't achieve correct contact between first premolar and first molar. Anchorage is provided usually by other teeth. It's a simple anchorage. We can use anchorage on the anchorage could be palate. For example, if we use Nance appliance, external anchorage, it could be head or neck. In this situation, we use external appliances like headgear or face mask, and skeletal anchorage. We talk about this a few times. It's a kind of maximum anchorage. Now, other tip. In this situation, it could be tip in the same arch or in the opposite arch. If these are tip in the same arch, we can use long ligation or TPA, transpalatal arch. I will show you this on the pictures. And in the opposite arch, it will be, in this situation, we use intermaxillary elastics. Okay, what you should know? You should know anchorage value of tooth. So we look at this is equivalent to its root surface area. And if we want to have more anchorage, reinforce this anchorage, we connect this few teeth together, and in this is a method to reinforce anchorage. Okay, you should to know that the biggest anchorage has upper first molar, you see the value, and the smallest lower central incisor. Of course, you should know how to estimate the value of anchorage. The central incisor has biggest anchorage, then lateral and lower incisor. You should know that the canine upper and lower has also very, very big value of anchorage. And of course, if we are planning the movement of this kind of tooth, we can expect that the movement will be not very, to achieve this kind of movement, it will be not very easy. Easier is achieve the movement of the incisor than upper canine. Long ligation. So to reinforce anchorage, we can connect more teeth together. TPA. This is also anchorage in one arch, so we connect both first molars. But remember, this kind of anchorage is only moderate anchorage. Moderate, nowadays we also estimate this kind of anchorage as minimum anchorage, because in fact we still observe the movement of this teeth which are connected with this. So it's not huge anchorage, rather between medium and moderate anchorage. So if we don't want movement of the buccal region, we should to use microscope. Intermaxillary elastics. So this is anchored in both arches, in opposite arches. So we can use triangular anchorage or this kind of anchorage. These are elastics for treatment class 3. So we call this elastic class-free. Why? Because it pull backward or this tip in lower arch or forward in upper arch. Here we have elastic for class 2. You see over jet is bigger over jet, so probably class 2 division 1. And what's happened here? All this teeth in upper arch go forward and teeth in lower backward, and teeth in lower arch go forward. Elastics in class 2 will work if we have class 2 cusp to cusp. If we have full class 2, it's rather not a good idea to use elastic in this treatment because we couldn't expect that we finish with correct classes. If the patient cooperate, wear this kind of elastics, and we have class 2 division, class 2 cusp to cusp on canine, on molars, we can expect that we will treat this method our patient. Once again, class 2, class 3 elastic. Usually we give this elastic in this kind of packs, and we ask patient to wear it on each one side, usually a few hours per day and during night. NANS appliance. NANS appliance is not impacted. This is modification of TPA. As you see, we still need two bands connected with the wire, but look, here we have acrylic bottom, and this acrylic bottom is localized in the anterior part of the palate. So this part of the palate, in fact, is anchorage. And if we want to estimate which kind of anchorage is better, NANS or TPA, in my opinion, better is NANS. But in many books, I found that it's very similar kind of anchorage. But I disagree with this opinion. Okay, extraocular anchorage headgear and face mask. Headgear, as you see, this is high pull headgear. We have three kinds of headgear: high pull headgear, low pull headgear, or also it's called cervical pull headgear, and combi headgear. So it's combination of both kinds of headgear. Okay, so here we have elastics, and here is face bow. This is extraoral part. The patient has also intraoral part. I saw you this appliance 2 weeks ago during lectures. And this is a place also because we can use it for intrusion, for extrusion of upper molars, but for distalization, we can also use it for anchorage. But as you see, rather it's difficult for the patient to use it for all the time. So usually patients use it for during the night and sometimes few hours when they are at home. This kind of a place is associated with huge discomfort. That's why nowadays it's not a good anchorage. Many years ago, when we don't know implants, we don't use implants. This is a method to reinforced anchorage, to have better anchorage. We add to TPA this kind of appliance. But nowadays, it's not a good idea to plan in the patient treatment as an anchorage headgear. Usually, it should to be wear 10 to 12 hours per day, and you know that it is impossible. Face mask. Face mask appliance also for treatment anterior posterior malocclusion. The patient use it for treatment. We use it in group of patients with underdevelopment of upper jaw, and it is possible the disciplines works in a group of patients under 10 years old. Because at this time the suture between zygomatic bone and maxillary bone is still elastic, so we can achieve advancement of upper jaw. Okay, and where we have anchorage is on the forehead and on the chin. Of course, this part is stable, this part is mobile. That's why we can expect when the patient uses distal rotation of lower jaw. Remember that in your book, the face mask is also called reverse pull headgear. Reverse pull headgear, but remember, it's not a headgear, it's in fact face mask. So if you have a question during quiz, don't choose that headgear is for treatment class 3 with underdevelopment of upper jaw. Okay, implants, nowadays we don't use it very often, this kind of implants, but that's are used very often during orthodontic treatment. What it means, it's temporary anchorage devices. It's a very small kinds of screw. This kind of screw don't osseointegrate, so we don't expect that there will be connection between this micro screw with the bone. So we insert it into the bone for the few times for planning orthodontic treatment, and then we can easily remove it. Usually when we are placing it, we use local anesthesia, and when we remove it, usually the patient don't need anesthesia. It's not connected with a huge pain, so rather it's also very, very easy to remove it. And this kind of implant could be loaded immediately. So in fact, we should to add some kind of force to this micro screw very fast after insertion. Why? Because if we wait too long, we observe that surrounding mucosa will cover all this implant, and then we have problem because we should to ask surgeon to find for us this screw. Okay. Absolute anchorage remains an orthodontic holy grail. So always when we are planning orthodontic treatment, we think about the anchorage. Okay. Implant. What is this implant? Implant is a material remaining in the body for a period of 1 month. So everything which we insert into body for 1 month, it will be called implant. Screw. Why? Because it's very similar, especially a treating part, to the screw. You can see it here. Okay, mini, micro. Very often, students use the word mini implants, orthodontic mini implants. What is important here? Thread diameter over 1.9, and here in micro, it's less than 1.8. And in fact, all the implants, orthodontic implants, are micro screw. We don't use rather this kind of diameter. So you can see here 1.2. It's very, very small, very, very thin. It's a possibility to we can expect that this kind of implant could broken during insertion into the bone or when we're planning to remove it. This is very thick. Usually we use 1.6 diameter of the screw. What is okay? Features of orthodontic implants. These implants are made of biocompatible material, so it could be surgical steel, vanadium alloy, or titanium alloy. Look, it's a very, very small dimension only this part is in bone, this part is under the mucosa. Rather, it's easy to place and removal, especially for surgeon. If we talk about placement, removing of this micro screw is easy for everyone, and it can be immediately loaded. Okay, but what we should to remember that these mini implants are not in also integrated implant, and after the insertion, we shouldn't load these implants with a huge force. Usually, we use minimal force at the first 2 weeks due to inflammation, and we usually ask patients to use medicine. And after this time, we change the force for bigger. Self-drilling and self-taping implants. Self-taping implants require drilling before insertion. Self-taping, in this situation, we don't need the barreled hole before insertion of this kind of implant. Indication for orthodontic implants treatment. First, anterior segment intrusion. It could be symmetrical, asymmetrical. I will show you the cases. Buccal segment intrusion to close open bite. We know that if we make intrusion of buccal teeth in buccal region for 1 millimeter, we can close the space in anterior region for 2 millimeters. Mesialization of teeth in the upper and lower jaw. When we are planning closing gaps, it could be symmetrical, asymmetrical distalization of teeth in lower and upper jaw, retraction and mass of the front teeth. What does mean en masse? Earlier, if we make decision about extraction of first premolar, we couldn't think about closing these gaps after extraction by distalization of all the anterior teeth at once. So first, because we could lose the anchorage. So first we make distalization of the canine, and then we connected this canine with buccal teeth, and then we make distalization of anterior incisors. Nowadays, when we use microscope, we have huge anchorage, so we don't expect movement of buccal region because we are connected with the bone, and these microscopes are connected with the bone, and we bring the anterior teeth to these microscopes, so we can make the distalization from canine to canine at once. This kind of retraction is called en masse retraction. We can achieve uprighting of molars. We can also use this groove when we are planning anchorage for activation of impacted teeth. But nowadays we don't use very often the micro screws on the palate. Of course, we can use it, but we use templates to. And first, we should make CBCT examination to estimate precise the position of these micro screws in the palatal bone. Earlier, yes, a few years earlier, about 10 years earlier, everyone insert this without CBCT, without templates, but nowadays we know that it's not a good idea to do this like in this way, and that's why we make modification of this method of treatment. Further encourage so palatal microscope for upper jaw expansion and for distalization. Also, this method of treatment, when we are planning, we should use CBCT and templates to do this. Now, construction of micro implant, we have head, neck, and threading part. This part is in the bone, this part is outside the bone, this is above the gingiva. Here, as you see, we could have the space, we can use here elastic, we can use here wire in this hole. So there's a lot of possibility of connection with this kind of micro screws. Sometimes we have something like a bracket with a slot, so we can also use the typical orthodontic wire in these implants. Here you can see information which we have about this implant. Some kinds of implants are sterile. We can buy it after sterilization, or some are not sterile. And in sterilization, here you have information about the length of this implant and about the diameter. If we have some implant in different diameter, you can see here 6 millimeter length and diameter is 1.7, and here is information about the slot, because this kind of implant they have a bracket with a slot. Okay, screwdrivers. Different kind of implants have different screwdrivers. This was 3M company screwdrivers. This for palatal side, this for vestibular side. Where we can insert this micro screw. Palette, I told you that we use a template when we are planning to insert the implant somewhere here in mandibular retromolar region. So here, in this region, we use 10 millimeters micro screw. In different size, usually 6 to 8 millimeters micro screw can be used. Is the length of the threading part. Here you can see this is Ortho Easy company micro implants, and these implants, as you see, have a slot here, so we can use wire, rectangular wire, to put it into this implant. The Ortho Easy implant, which we put in the from the vestibular side, 6, 8, 10 millimeter length. This is for rectangular part, and this is for palette implants. And appliances which we can use when we use the on implants for distalization, here for correction of the molars which have mesial inclination. Once again, this is to uprighting the first molar. We can use it here, micro screw, and here is this is tube, typical tube, and this is the part of the appliance for uprighting. This is frog appliance for distalization, and here you can see how the micro screw could be inserted. Nowadays we don't do this like you see here. So earlier we make temples, so we estimate correctly, precise when this implant should be placed. Because in this way, we, after inserting the implant, it could have a contact with the root of some of the teeth here. Okay, maybe it goes in. Wait a moment. Maybe not. Yesterday it works, but today maybe not. Okay.
One test and who's resting?
This is first, here you can see the first pair of implants. We don't use so many instruments to insert it nowadays.
So which day for gym today for you?
Which part? Glutes. Glutes.
Sexy ass.
Yeah. No, certainly I didn't spend a lot of time at the gym.
Or puncher, they also call this puncher. First, local anesthesia
I like your dress.
for injection.
I need to tie it, because I don't want people can see my boobs.
No, you have beautiful boobs.
Yeah, but only my future boyfriend, can see it.
I always envy this kind of boobs.
The punch is a kind of mucosa, so it makes a space, it cuts the mucosa to make a space for implant here. It's better not to place it in this moving mucosa, the micros, because we have a problem then with inflammation.
It's too dark. I don't see.
See, if you cut this part of the mucosa,
Do you think should I do double with double ingredients or what?
You mean to layer?
No, I mean I think one is enough.
Yeah.
Can I take it?
Yeah, sure.
Do you have
Tissue.
Dry glasses?
What do you mean dry glasses?
I mean this one is wet. I want the dry one.
Oh, yeah. You want me
No,
to
it's too big.
small one?
I miss the cook with you.
Or is it too small for you?
No, I can handle it. The big one is more problem.
Because if you want bigger one, then take the bowl. easy teaching for you.
Mm.
I'm going to take a shower. Did you mind?
No, it's okay. I'm the big chef today.
Yeah.
Okay, and here I will show you a few cases of treatment of the patient when I use microscopes. First, asymmetric intrusion of anterior segment in the upper jaw. Sometimes we have a patient who the biggest complaints is in fact this kind of problem. So huge asymmetry of the occlusal plane. This is intraoral situation. You can see that also on orthopantomogram, you can see this situation. So where we are planning in this case, the micro screw position. So the best is to plan this position asymmetrically in this region. Why here? Here we have not enough space. Here it will be more difficult, and during insertion we can hurt the roots of neighbor teeth. That's why better place it will be here. And you can see the patient. This is micro screw. It's very small, but it depends what kind of implants this situation use the surgeon. So sometimes it looks like this, sometimes it's bigger, but this is the patient after 3 months of treatment, and you can see the level of the upper plane, plane of upper arch. So you see that here we use stainless steel, hard, not flexible wire. Here we start the treatment lower arch. That's why it's still elastic night-eye wire. You see that we achieve the correct level. The same patient before after treatment. Here we have a little overgrowth of the gingiva. In fact, it's not a huge problem. Usually we see it when we remove the braces. This is a patient. At the same day, we make a picture when we remove the braces, because usually we make a picture just after removing the appliance. We make the picture for them. And when I meet with the patient for 6 weeks, after this time, usually it looks much more better. They have no problem with this kind of gingiva, but you see that we achieve a good correction of the surface in upper jaw, occlusal surface. We can also treat patient with intrusion, symmetrical intrusion of anterior segment in the upper jaw. Here you can see the patient. This patient has a little gummy smile and the bite. So if we have this kind of situation, we rather think about intrusion of the teeth in upper arch. And here you can see Ortho Easy microscope much more bigger. And symmetrical intrusion, you can see the effect. We have a half of the overbite is in the situation decreased. So the upper incisor cover lower incisor less than a half. So we achieve correction. Remember that we are never planning huge intrusion, because it's rather very invasive to movement, and we can expect resorption. And We should remember that if we have a young patient with gummy smile and he show us 3-4 millimeter of gingiva, probably if this girl will be after 15 years old, he will show us 2/3 of the crown, upper crown, and more lower incisor. That's why when we are planning intrusion, we don't plan very big intrusion. Distalization. Sometimes we have situation like here, patient with class 2 division 2, you can see class 2 cusp to cusp. When we use microscope, on the other side we have class 1, you don't see it here now because this picture is not as good as it should be, but it's rather easy to achieve correction with microscopes when we are planning the treatment, the movement from class to cusp to class 1. And you can see it here. So it's the same patient, of course. Here, mechanism for distalization, and here is microscrew. The microscrew is inserted between the first molar and premolar. In this situation, we always remove the bracket from the second premolar. Why? Because we are in this situation, we expect that the root of this tooth during distalization will change the position. If it will be connected with the wire, we expect that it goes into the microscrew, and we expect resorption of this tooth. Here you can see this is this microscrew. I made this photo when I put the TPA, for what we use TPA, of course, for anchorage. So we achieve correct distalization, and I want to keep this both molars in the same position. That's why I add TPA, and then I remove this microscrew. And here the distalization which we achieve during this treatment. Once again, the same patient, and correction in upper arch, and the effect of treatment. You can see, I hope that you remember, this is this patient before the treatment. Look what's happened here. This, in fact, it's incorrect position of this tooth. Patient bite very hard, use big power. So this is connected with incorrect position. Feston McCoy's, you can see it here. But what's happened when we finish? We have beautiful gingiva here. It was only orthodontic. Okay, you can see it here better. It was only orthodontic treatment. I don't ask a patient to go to the periodontologist, so the patient don't need this kind of treatment. Distalization of the anterior segment and mass after extraction of the first premolars, and here is the patient. As you see, huge protrusion in both arches, incisor in lower upper arch, intraoral situation, you can see it here, crowding, incorrect position. So we're planning extraction on both sides, the premolars, and here you can see distalization en masse in upper region. And here, effect after orthodontic treatment. Mesialization, it's not my patient, but you can see that we also can achieve mesialization of the buccal teeth to close the space if we don't want movement of anterior teeth, but only want to mesialize the buccal teeth. We can use microscrew like here. And the appliances which we can use for distalization, it is based on micro screws. Now we can do this kind of plans. And bump. Bump is also this method. What does mean this? B, bone anchorage maxillary protraction. Hugo de Klerk found the bollard plates, mini plates, like this. And here we have 3 screws, 2 screws. This is in the maxillary bone. This is in lower jaw between the lateral incisor and canine. And here we have the hooks and elastics. This is a method of treatment class 3 with underdevelopment of upper jaw. If the patient is over 10 years old, we still have possibility for correction of class 3. But in this situation, we need operation to place these mini plates and then next operation to remove it. Nowadays it is also very expensive in our country. We have few patients which were treated for free because have this kind of possibility, but nowadays it's very expensive, and in this situation patient needs to operation with general anesthesia. That's why we don't use this method very often. In this situation the patient wear this elastics all the time, but the power which we use is much more smaller than this one which we use during treatment with the pacemaker. Thank you for attention. Do you have a question? Okay, don't please be connect, because I see that one person disconnect with us. I should make a list. Okay, so thank you for attention. You can disconnect now.